Hello, everyone. Welcome to another episode of Hot Mic Cold Virus, where I get to sit down with various guests and take a deep dive into infection prevention and various hot topics. My name is Rochelle Beard. I am the host and also an infection prevention and quality improvement consultant from the Louisville, Kentucky area. I'm excited for episode 3 today, where we are going to talk all about measles. I'm here with my friend Meg, and I'm going to go ahead and let you introduce yourself, Meg.
Hey, I am Meg Sorg. I am, lots of things at the moment. My background is as a pediatric nurse and a pediatric nurse practitioner. I have taught at the Purdue School of Nursing, and I'm currently a second-year medical student interested in going into primary care pediatrics. And so I have a major interest. I'm also a mom of 4 kids and lots of interest in measles and pediatric healthcare.
So before we really get into the content, very important question. Have you been invited to any measles parties lately?
I have not. I'm not aware of any going on around me, but no. I would decline that invitation promptly. Also.
Yes. I saw a friend sent me a post on Instagram about like chickenpox parties of the 90s are back with people doing measles parties. Official statement of this podcast. We do not condone measles parties or chickenpox parties or
COVID parties or
none of those. We are, or wait, you condone, which is the one you don't support. We don't support.
I do not condone.
Yeah. It is not good. You do not want to just go give your kid measles and get it over with, because you don't know, which we're going to talk about. You don't know how your child is going to respond to measles, or how yourself, if you're an unvaccinated individual, is going to respond to measles, and what kind of complications are going to happen. So don't do it. Decline. Don't even decline with regret. It is just hard decline.
RSVP, no.
Yes. All right, so I do want to jump in to some history here. So I did a little research, and measles became a nationally notifiable disease in the United States in 1912, so over 100 years. For the first 10 years, an average of 6,000 measles-related deaths were reported each year. So definitely a big problem in the early 1900s. In 1963 is when we got the vaccine with what was called the Edmundston B strain. This was a non-live vaccine and was given to under 1 million people, so not a ton of people. It did kind of help a little bit. And before that, there were estimated 3 to 4 million people who got measles each year. 400 to 500 of those people who got measles died. Around 48,000 were hospitalized, and then of those, 1,000 people would get encephalitis, which I know we'll talk about. So in the 1953, remember the vaccine came out in 1963, there were over 5,300 cases with 440 deaths. So that was the 10-year span leading up to the 1963 vaccine, with a case fatality rate of 1 in 1,200. And then in 68, we got a better, weaker vaccine. So this is the live vaccine. And then in 1978 was when CDC set the goal to eliminate measles in the US by 1982. By 81, reported cases were 80% less, but not considered eliminated. By 1989, having measles outbreaks in vaccinated school-age kids still a ton. And so that's when they recommended having that second dose of the measles vaccine, which was encompassing measles, mumps, and rubella, I believe, by at that time. And then fast forward, by the year 2000, we finally were able to declare measles eliminated from the United States. And what gets a virus or a disease eliminated from the United States, it means that there's no continuous spread for over 12 months. So that's where we were. Have anything to add with that history? It's over the last 115 years or so.
I would like to add one little point, because I've had people who are vaccine skeptical, we'll go with that word, talk about how the death rate was actually decreasing prior to the initiation of the vaccine. And that is consistent with the history that you gave. But I think it's really important to point out that that is not that there are lots of factors that went into that. We had improved sanitation. We had penicillin at that point. And as we'll talk about in a little bit, one of the most common causes of death from the measles is actually due to a superimposed bacterial pneumonia. And so the fact that we were seeing fewer deaths doesn't speak to the decreased danger of the measles virus. Prior to the onset of the vaccine, it actually just speaks to the fact that other things were going on historically in those years also. It still remains a dangerous and highly virulent disease. And so just wanted to throw that in there.
Yeah, very good points. Why everyone's like, oh, hardly anyone dies from the measles these days. Yeah, that's great. But it's not because measles is really less dangerous. We just have way more adjunct things that are making it better, but still not safe for sure. So let's talk a little bit about what measles actually is. So measles is a virus, can also be referred to as rubeola. It's super contagious, lives in your nose and in your throat, and then in the mucus that's in there. So contagious that if one person has it, in the surrounding area that you come in contact with, 9 out of 10 people who are not immunized will be infected, which is terrifying.
Yes.
Absolutely terrifying. Another thing, the air droplets, it hangs around for up to hours in the air. So even if you were in a room, we'll say a doctor's office, and that person leaves, assuming the air exchanges are not like flipping around like it is on like an airplane or something where you've got it every couple of minutes, then that virus is hanging around suspended in the air, and anyone for up to 2 hours in that room is going to be considered exposed to measles. And if they are not immune, very highly likely that they will get measles.
Yeah. And the scary thing about the infectivity period is that it is highly contagious for up to 4 days prior to the onset of symptoms. And so people who are infected with the virus may be spreading it around before they even know that they're sick.
Which is terrifying.
Yeah.
Because people don't stay home when they're sick, and they definitely don't stay home when they're not sick. So we talked a little bit about how it's dangerous. Doesn't mean just because no one's dying doesn't mean it's not dangerous. I found some information that I kind of thought was interesting, the way they divided up who was at risk. So like kids under 5, these are the highest risk, kids under 5, and then adults over 20. So really you're only like, your best time is like age 6 to 19.
Not the best time anyway. Like
right. I mean, you're doing everything during that time. At least you think you are when you're like living in the dorms and in college, or I guess that'd be just the beginning of college, maybe. And then pregnant women and people who are immunocompromised. Those are the highest risk categories. So that's not few people. Like, it's not just the very young or the very old. It includes majority of people only. And just because you're 6 to 19 doesn't mean it's still not dangerous, but it's not the highest risk category. You talked about the signs and symptoms, and so let's go through the kind of like flow of measles. So you get signs and symptoms 7 to 14 days after exposure. So part of that time is when you can go ahead and start being contagious and you don't know it. You usually start like any other virus with a high fever, cough, runny nose, sometimes have conjunctivitis. After you have those symptoms, 2 to 3 days after, you might get what's known as Koplik spots, the white spots inside the mouth. And then 3 to 5 days after that is when the measles rash comes. So if someone's looking for a measles rash, how would they identify that over like another viral rash? What would be some telltale signs that people should look for?
So first of all, is that rash with the fever? And that's going to be really important in distinguishing measles virus from a virus like roseola, which is a harmless viral exanthem meaning rash, that starts after the fever has resolved. So we've got the rash with the fever. This rash is going to be a red rash. Initially, you're going to be able to blanch it. So that means if you push on it, it's going to turn from red to white. Oftentimes, it's going to start back in the head area, oftentimes behind the ears, along the hairline, and then it just kind of becomes confluent over the body. It is going to go from the head down, and then it's going to recede in the same order that it appeared. You may see some peeling that goes along with that. We call that desquamation. And so those are going to be some of the key features. It can look a lot like other viral rashes. And so as clinicians, especially, we have to have a high suspicion for measles whenever we start to see a kid coming in with fever and rash.
Which is every kid all the time.
Yep.
But this is when a good history comes in handy. So you want to look into travel. You want to look into vaccination status, potential exposures, because if the kid is fully vaccinated and has a rash and a fever, then it doesn't mean it's not completely outside of the differential, but it's going to drop down a few rungs because it's not going to be your top thing. Maybe it's human metapneumovirus or something along those lines. But it's very important to use that history to help decide what direction you're going to go.
We call we have the 3 C's for measles. So cough, coryza, and conjunctivitis are going to be the 3, I guess, pathognomonic or maybe not pathognomonic. Koplik spots are going to be pathognomonic. They're going to be the ones that kind of say, hey, that's what this is. So we need to be looking for those, which, as you mentioned, are those spots in the mouth. And then we've got those 3 important findings of the cough, coryza, and conjunctivitis. Coryza meaning like the watery eyes and watery nose, coughing, obviously, and then the red eyes.
You read my mind. I was going to have you define coryza. So thanks for that. Another thing about the rash that I've heard people describe it, it's like you poured a bucket of paint on their head. So that's the way it kind of falls down the body. So what are we looking at duration wise? So we've got a couple days with symptoms. And then we've got 3 to 5 days that you get the rash. How long do people usually have the rash? Do we have a set time?
4 to 7 days. So that rash can hang around for up to a week.
So you're looking at a good 2-week illness almost.
And then the cough can hang around for that full 10 days, also.
Yeah. So in describing these symptoms, you could look at it and be like, okay, just sounds like an annoying virus, which I would say is just as annoying as the thing I'm dealing with now, almost. So apologize to the listeners for the way I sound or the cough breaks that I have. But what is it that really sets measles apart as being a significant illness we need to pay attention to? Because the way we just described it does sound kind of mild, but where's the problem come in?
Sure. So measles has actually, this has been an argument that I've heard also, it has a lower fatality rate or case fatality rate than viruses like the flu. Flu has a significantly higher mortality rate, and I would advocate to get a flu vaccine also. The concerning things with measles really have to do with more of the long-term sequela versus the short-term. So pneumonia, as I'd mentioned earlier, is going to be the most common cause of death. And that usually comes from a bacterial superinfection. So your immune system is busy fighting the measles, and then a bacterial pneumonia from a bacteria like strep pneumo or Haemophilus influenza comes along and says, hey, let's kick them while they're down. And that is really the most common cause of death. And that happens relatively quickly. So you would see that within the realm of that initial infection. You can also get things like ear infections. You can get croup or laryngotracheitis. You can see some GI infections that go along with this also. And those types of symptoms, which as parents, we see happen from basically any other virus. A kid gets a cold and they can develop an ear infection. Those things we can treat. Pneumonia, definitely more serious, and like I said, is the leading cause of death. Then you get into more of the severe neurological consequences or potential complications. You can see meningitis or inflammation of the meninges associated with this. Some patients will develop an acute encephalitis, which can be fatal in and of itself. To me, one of the scariest things that can happen with a measles infection is something called subacute sclerosing panencephalitis. And that's a big word, or a big couple of words there. But basically what that is it's a generalized demyelinating inflammation of the brain. And this is due to a persistent infection. And so this you're not going to see within the first week after illness, within the first year after illness even. You are going to see this develop 7+ years after that initial infection. So you can get this virus it is terrifying. You can get this virus as a baby, and then whenever you're 8, 9, 10, 11 years old, you start developing these symptoms. And SSPE is lethal. It kills people. And so what you see with this is you start to see personality changes in your kiddo. And then they progress to having seizure activity, which further progresses into, you start to get decerebration. So the cerebrum is affected, or excuse me, the cerebellum is going to be affected, and then you move into a vegetative state, which leads to autonomic failure and death for kids. It's a rare complication. However, it is a significant and serious complication that, like I said, doesn't manifest until years later. And that to me as a parent is absolutely terrifying.
Yeah, not something that I'd want to just like play roulette with getting when you have a safe alternative of being immunized, and not having to really worry about that. Yeah, that's terrifying. Some other complications we talked about, people who are pregnant having issues. It can cause premature birth, can cause low birth weight in the fetus or the baby when they're born. Let's see. You mentioned about the pneumonia. That's the most common cause of death in young kids with measles. Also, most common reason for hospitalization. A lot of this information that I got, I think everything that I researched, I got from the various pages on the CDC's website. And one of the stats that they had on there was that 1 to 3 in 1,000 kids will die from respiratory and neurologic complications related to measles. So that could be from pneumonia, from encephalitis, or from that SSPE.
Yep.
So not something you really want to play around with.
No, not at all. And I mean, could make the argument that that's rare, but I would not want to take that chance when there's a safe preventative option.
Yeah, same. Another thing that I find frightening about measles is this thing called immune amnesia. I'm going to say that the SSPE and this immune amnesia, while I think are some of the like scariest complications of measles, I definitely think they're the lesser known. Because up until, I don't know, a few years ago, I listened to a podcast from called This Podcast Will Kill You, and they talked about immune amnesia, and I had never even heard of it. As in nursing school, master's degree, infection preventionist, had no idea that that was a thing.
Yeah, it's not something that I have thankfully ever seen with working with kids. It's something that I guess I more associate with after having had a stem cells transplant or something like that wipes out. That's a little bit different than the amnesia, but it basically wipes out your immune system. So
yeah, I looked into it to figure out kind of how it works. And there's not a ton of I feel like research into it that much, but basically measles ends up resetting your immune system, replaces the old memory cells of its host with a measles virus specific lymphocyte. So it's so strong. You have like a super strong measles immunity after you get measles. You're increasingly vulnerable to everything else except measles. So lots of pathogens like can suppress your immune function. Like if you get another illness, like right now, as I have a cold, I'm susceptible to other things. This virus is suppressing my other immunity, but this like kind of takes it to another level in the sense that measles apparently is unique in the ability to destroy and replace the memory with the measles specific memory. So you're probably good to go forever on measles again, but like I would be very upset if I got measles and erased the immunity that I am building right now with this virus that I've been going through for weeks, I feel.
To schedule some more chickenpox parties.
Right. Start working, get on Pinterest for your invitations. But so a very high level general summary of this is like measles binds to your memory B and T cells and the naive B cells. Clearance of the virus involves elimination of the infected lymphocytes and then destruction of those memory B and T cells, which means the memory of your past infections is going to be destroyed also. So kind of similarly to, I feel like when you use antibiotics in the sense of when you treat something, you wipe out all the bacteria. It's not the same exact example, but kind of like when you're at risk for other infections after you take an antibiotic because you wiped out all the bacteria, the good, the bad, the ugly. This ends up destroying your immune memory for the other pathogens that you've been exposed to. So now as your new cells are created, the only memory that they have is going to be your measles virus memory. Some studies that I looked at say that it takes 2 to 3 years for protective immune memory to be restored. So you're basically being reset to a newborn and you got to get sick with everything all over again to build it back up. I know, so inconvenient.
Do you know, did any of the studies look at re-immunizing against other pathogens in that time period, or did they not talk about that?
They did not talk about it, but that would be something cool to look into. I feel like it's probably hard to track down this.
Well, I mean, when these things are happening, whether it be a couple of weeks later or a couple of years later, oftentimes you don't necessarily link those things to something that happened several years ago. And so, yeah, I would see why there may not be a ton of data looking at that kind of stuff.
I would assume that you would like revaccinate against chickenpox and those kind of things if this happened. But I guess kind of like, how do you know? They'd have to
Like
go
drug
in
titers and things like that if it's suspected.
Yeah, but then everything else, like all the viruses that you've been exposed to and built up decent immunity to, like there's nothing you can do about that. Just you have to get it again and suffer through.
That is wild. No, thank you.
No. Anything else about symptoms and complications that we want to touch on before we move on to like, why are we talking about this now? What's going on?
I think those are the big things. And because of what's going on right now and seeing more cases of this, I think that, like I said earlier, it is really important to have a high level of suspicion. This is something that just a few short years ago was considered eliminated in the United States. And so many practicing clinicians have never seen measles in person. And so we've seen lots of kids in the ER, in the clinic, in the school, in the home, who have had fever and rash, and haven't necessarily had to worry about it being something so infectious and so potentially dangerous. And now that we're seeing numbers like what they are right now, that is something that we have to be thinking about.
Yeah, so let's talk about those numbers because, and these are not going to be up-to-date numbers because I did not go search any articles today. The last data that I pulled is as of March 13th. We are recording this on March 19th, 2025. The CDC is updating their measles data for these for the outbreaks on every Friday. So this is going to be last week's data. They close the data on Thursday, posted on Fridays. So this is data as of March 13th. 301 confirmed cases with 3 outbreaks in the United States. 93% of these cases have been associated with an outbreak. 95% of the cases are in people who are unvaccinated or in people who we have unknown vaccine status. Only 2% of these 301 cases were fully vaccinated. So it's a very small number. 17% of cases were hospitalized, with the majority of these hospitalized being kiddos under 5. We've had 1 confirmed death in a school-aged child and 1 death under investigation in New Mexico. This is a person who had measles but did not seek medical care, but did pass away. So they're trying to decide if that was a cause of death.
I'm just going to say 301 cases. You think, oh, when you think about all the people in the United States, that doesn't sound like that much. However, we're only mid-March and we're already above the total number of cases that there were in the United States in 2024 altogether.
Yes. I looked at the last year and then a couple of years that we had a ton of cases. In 2024, we had a total of 285 cases. 33 states were involved. I think right now, we're at 15 states currently. And then let's see, 16 of those there were 16 outbreaks with 69% of the cases associated with an outbreak. So when we say that a case is associated with an outbreak or not, a case that's not would be like someone that went to a country and where measles was endemic and they came back with measles. That's not an outbreak. That is just someone who got measles from an exposure elsewhere. So that's going to be a case that falls into a non-outbreak associated case. So just to kind of understand the difference there. 89% of the cases in 2024 were unvaccinated or unknown vaccination status. So right in line with what we're seeing this year. 40% were hospitalized, and majority of those were under 5 years old. That 40%, that's a lot of hospitalized cases. So there were a few years in the recent past, since the year 2000, that we've had more cases than the past 2 years. 2013, there were 667 cases. That's, again, the entire year. We're already halfway-ish to that, so won't be surprised if we surpass 2013. 2019, we had 1,274 cases. I hope we don't get there. I wouldn't put it past us, but I hope we don't get there. So yeah. Oh, and I was wrong. It's not 15 states, 14 states that we currently have now.
And isn't it 14 states and then DC?
Yes. Yeah. Correct. So do what?
I said in one jurisdiction.
Yes. So what have we got here? Our outbreaks that we've got going on in the United States. We've got an outbreak in Texas, started in January 2025. South Plains, Panhandle regions, heavy in the Mennonite community, and that's going to go down to that unvaccinated status. February 26th was when we had the child who was unvaccinated died in Lubbock, Texas. We've got outbreak going on in Asia as well. So you have to be cognizant whenever you're traveling to make sure you're vaccinated before you go, because you can be exposed wherever.
Yep.
So this is why I figure this was a good time to talk about measles. Bring everyone up to date, find out what's going on, and it's now's as good a time as ever to make sure that you get vaccinated and protect yourself and your loved ones from getting this lovely illness.
Always a good time to get vaccinated.
Yes.
I need a shirt that says that.
Right. We kind of talked about this. So when do we consider measles? We're going to look at that febrile rash you talked about, international travel, where you have a potential exposure, and looking at your vaccination status. How do you you probably haven't had to test for measles. I would assume maybe not, but how do people go about testing for measles, like in the doctor's office or emergency room or whatnot? How do they go ahead and diagnose?
That's a good question. So a lot of things can be diagnosed symptomatically. However, as you mentioned, measles is a reportable disease. And so getting confirmation of diagnosis is going to be really important. There are a couple different ways that you can do that. You can look at PCR testing. You can get a viral culture, which usually takes a little bit longer than the PCR testing. Or you can look at antibodies. Your IgM antibodies are going to give you evidence of an acute infection. Your IgG antibodies, which give you a little bit indication more of that long-term protection or long-term immunity. Those you can use those to diagnose, but it's more of a retrospective diagnosis. So you would take those, take one of those and look for a rise in your IgG antibodies. So ideally, you're going to do that. You're going to do one of the quicker testing methods, so looking at PCR, viral culture, or your IgM antibodies.
And if you suspect a measles case, you want to go ahead and do that testing. And then also, like, there are people that need to know.
Yes.
You need to let your leadership in whatever facility you are know you're going to have to be doing mitigation strategies, and risk is going to need to be involved because there's probably going to be exposures unless you actually, like, the person walked in with the mask and you put them in a negative pressure room immediately and there was no one around and all those things. And everybody is vaccinated and all that good stuff. But we know that's not how it works. And you have to let people know. You need to let your local and state health department know. And they're going to be involved when you're doing that testing and stuff too. So don't just keep it to yourself. You got to let all the appropriate people know. Right. So once we figured out, before we go into treatment, also, when someone is waiting for one of these tests to come back, they should not be going about their daily life and their normal business. If they are not already admitted to a healthcare facility where they are in appropriate isolation, they will need to be isolated in their home, not going out around others, because like we talked about at the beginning, 9 out of 10 people who are exposed to someone with measles, if they do not have measles immunity, will end up with measles. So while tests are pending, people need to be separated from others. So once we figure out that someone has measles, how are we going to treat them? What are the options? Because it's a virus, so we can't just give them an antibiotic. So what do we do?
Right. Mainly supportive care is going to be the mainstay of treatment. So for our kiddos, what that's going to mean is we are treating the fever for comfort. We are making sure that these kids stay hydrated, because dehydration can be a big issue with high fevers, and just general not feeling good. Kids don't want to drink as well. So those are going to be mainstays of treatment. There is some evidence to support the use of vitamin A in the treatment of measles. It has been associated with decreased mortality. That should be administered to kids who have severe measles or in those who are immunocompromised. But vitamin A comes with its own risks. It's a fat-soluble vitamin and can become toxic and can lead to its own neurological complications. And so that should not just be, you're not just going to go stock up on vitamin A from the pharmacy and take a whole bunch of that if you suspect you have measles. That needs to be prescribed and administered from a healthcare professional. There is a potential post-exposure prophylaxis for measles. And so if you have a known exposure and you know that your immunization status is negative, so either you are immunocompromised, haven't been able to receive the vaccine, or have chosen to not get yourself or your kids vaccinated against measles, then if you you can get the MMR vaccine within 72 hours. And that has been associated with both, in some cases, with not developing the virus, but in other cases with a decreased severity of the virus. And so those are some of the things that you can do.
And then if you don't end up getting it, then you're vaccinated. Good to go.
That's right.
Yeah.
Exactly.
So let's talk about the vaccine. Let's talk vaccination schedule with the measles vaccine, which is not just a single vaccine. We keep referring to it as that, but it is going to be measles, mumps, and rubella, or measles, mumps, rubella, and varicella, MMR, MMRV. So let's talk the vaccine schedule.
Right. So the vaccine schedule as posted by the CDC is, I'm going to talk about the traditional vaccine schedule, because when you get into the catch-up immunizations and all of that, it becomes a little bit more convoluted. However,
that'd be a really long podcast.
Yeah. The MMR schedule is relatively simple compared to some of the other infant and child immunizations. It is a 2-part vaccine. So the first dose is going to be given at 12 to 15 months. It's a live virus vaccine. And so ideally we do wait until that 12-month mark. There are some instances where kids can get that sooner if they're going to be traveling internationally. Then it's worth having a discussion with the child's healthcare provider to see if they need or if they should get an earlier dose. And so kids 6 to 11 months, 29 days, can get an extra dose of protection if they're going to be traveling internationally, especially to measles endemic areas. But on the traditional schedule, you're going to get it at either your kid's 12-month or 15-month well-child visit. And that first vaccine gives 93% protection against the measles virus, which is a hugely successful vaccine. The second part of that series comes at the kindergarten shots, or what we traditionally think of as the kindergarten shot. So between 4 to 6 years old. And with that, you're going to get up to 97% immunity against the measles viruses, which is really exciting.
Which is why you see those such low numbers in the data that I mentioned earlier, that 2% of the people who have measles currently in the United States with these outbreaks, only 2% were fully vaccinated. Yep. So that's fantastic.
And that in and of itself, and I don't know for sure with these, but that may have been due to it being 97% and they just fell within that percent. It also could be due to personal factors. If you've got a child who has a blunted response to the vaccine, things like that. So it might be, I can't speak to that for sure, but there are reasons why the vaccines are not 100%. And that doesn't have to do with the safety of the vaccine. It doesn't have to do with really the efficacy of the vaccine. It has to do with multiple factors that could be at play.
Yeah. Everyone's different, and you can't 100% predict how everyone's body is going to respond to a certain treatment or a certain vaccine. I would be a terrible infection preventionist if I didn't talk about herd immunity and the vaccine. So herd immunity is the protection you get when more than 95% of people around you are vaccinated. So if you are someone who cannot get vaccinated for whatever reason, or even for a personal choice too, if everyone else around you is vaccinated, then the likelihood of measles getting to you is very slim, because it can't take a hold of the population around you. So it can't infiltrate your community, which is what's happening with the community, the Mennonite community that did not have that 95% vaccination rate. That's how we got measles eliminated from the US in the first place, is this herd immunity with everyone being vaccinated, not over 95%. Unfortunately, I looked at the CDC map last week. The only 11 states in 2023, 2024, only 11 states were 95% vaccinated. And this is looking at kindergarten population. So only 11 states with fully vaccinated MMR kindergartners in 2023, 24. And with that, even if your entire state has that 95% rate, I guarantee you the breakdown of school districts is different. So just because 95% of this is not accurate, 95% like in Kentucky of kindergartners vaccinated, that is not the number. Do not quote that. Doesn't mean that 95% of the students in Jefferson County are vaccinated at kindergarten, or in Greene County. That doesn't mean that they're all 95%.
Right.
Greene County could be 65 and Jefferson County could be 84. But then when you average them all together, they could go up to that 95%. So that doesn't even mean that that's great coverage either in those 11 states.
I was going to say, I think that it's important to point out that there are contraindications for some people to having the vaccine. Kids who are severely immunocompromised, so those kids who have SCID or other severe immunodeficiencies, it's a live vaccine. And so their risk of actually developing complications from the vaccine itself is higher than the benefit of them getting the vaccine. So they rely on that herd immunity. Children who have undergone stem cell transplants or who have a history of anaphylactic reaction to vaccine components, they're not eligible to get this vaccine. And so they rely on the protection of the people around them, that herd immunity that you were talking about, to be protected from this virus. And so I think it would be remiss to not talk about the fact that there truly are people who cannot get this. It would be unsafe for them to get the vaccine. But it would be incredibly unsafe for them to get the virus itself. And so the onus really falls on those of us who are able to get the vaccine to make sure that we stay up to date with ours and that we do provide that protection for other people. And, I recognize that there are many reasons why someone would choose not to vaccinate, or maybe they don't have access to get to vaccination centers. There are lots of things at play as to why people are not vaccinated. And I think that speaks to the importance of healthcare providers to, one, have compassion for people and their reasonings, two, to be informed themselves so that they can spread true information and combat misinformation, and three, to meet parents and people where they're at so that they can have conversations to make informed decisions. That's a real passion of mine, is let's talk about what your concerns are for not wanting to get this vaccination and how can we safely align ourselves to keep you and your family healthy.
Yeah, and with that, you may or may not be able to alleviate the concern. But you're going to get closer to alleviating that by having the conversation. You can't assume that everyone doesn't want to get a certain vaccine because of the same reason. They may have had a family member who had a fatal reaction after a vaccine, and it may or may not have been associated, but that's where their brain goes. They could be just flat out terrified. They could think it misaligns with a belief. But assuming that everyone has the same reason is not helpful for anyone. But you got to have those conversations, and then dive into the data and the information and have those open conversations. Because you're right, you can't just be like, "That's stupid. You should get vaccinated." Because no, people aren't making these decisions just to. They're not because they don't care or whatever. They have reasons. And so we have to really discuss it and figure it out. We wrap up. I do want to talk a little bit with the vaccine. We talked about kids and who needs to be vaccinated, but there are going to be some adults that still need to be vaccinated as well. So if you were one of those people who received the non-live vaccine in the 60s, that under 1 million people, then you should, if you have not already, get vaccinated with the current MMR vaccine series, because that one was proven to not do much. There's also the whole, like, if you're born before 1957 thing. So if you have had one vaccine, that was the live vaccine, and you were born after 1957, you should be good. Unless you're at a higher risk of exposure, like international travel or healthcare worker. If you're working in an outbreak setting, you may want to go ahead and get a booster if you fall in that category. But if you don't, then generally good to go. If you have had 2 doses of measles, mumps, rubella vaccine, the live vaccine at any point after that 1960s vaccine, you should be good.
Mm-hmm.
You don't necessarily need vaccination if you were born before 1957, because it's very possible that you already had measles, and measles gives you fantastic immunity that we talked about earlier. Want to confirm that, you can confirm infection through doing a lab test, or even if you're like, I think I got vaccinated, but I don't really know, you can do titers as well. Caveat, sometimes your insurance may or may not cover it. That's a whole different story, but there are tests that can verify if you want to find out.
I feel like during pregnancy, they usually draw the measles, mumps, and rubella titers.
Yes.
And so if you are a woman who has had a child, you should be able to have access to those records and see if you're curious about your immunization status.
Yes. So to wrap up, how should we wrap this up? What do we want to leave our audience with here? Meg, any profound words of wisdom?
Profound words of wisdom. The measles vaccination is safe, it's effective, and it's important. And we are hopefully going to be getting into warmer weather soon and out of cold and flu and respiratory virus season. And so sometimes we push those to the back of our head and don't think about it until they start circulating again, usually in the fall when the temperatures drop again. But get your protection now, get your kids protected. Flu shots are still available, so let's get protected against the flu. We'll see what's to come down the pike for next year's respiratory season, but stay vigilant and stay healthy.
And decline measles parties. Yes.
Click no.
Well, that's going to wrap it up for us at Hot Mic Cold Virus. Thanks again to Meg, and hope you guys will join us for the next episode. As always, if you would like to contact me with any questions or follow up about the episode or any of the other episodes, or if you'd like some infection prevention or quality improvement consulting, you can reach me at my email address, RochelleBeard@outlook.com.